All right, so we're going to talk about toxic effects of drugs. I just feel like this is an important chapter to focus on and really go through each slide. So this is your chapter 3, but regardless, it doesn't matter if you're using a different textbook or just want to listen. It doesn't matter what chapter it is. This is all about adverse effects of medications. So what are adverse effects? Well, it could be a side effect to medication you're taking, or it could be your body just somehow does not like the medication, or maybe there's an overdose of medications. Those are all part of adverse effects of medications. There's different types, and actually my screen's not showing the bottom, but it won't let me move it, so I'll just let you know what's on the bottom. Okay, we have primary actions. That means you took too much. So it's an extension of the desired effect. Took too much of something. A secondary action. So this is an undesired effect produced in addition to the pharmacologic effect. So for an example, I take, let's say I take a cholesterol medication and I get muscle aches. Well, a muscle ache is a secondary action. It's an undesired effect. Hypersensitivity, excessive response to primary or secondary effect of the drug. So it's an excessive side effect, so you break out in hives, you're hypersensitive. So that's an example. All right, so there's different types of drug allergies. Now this is just a little side tip. When you ask people what their allergies are, many people will be like, well, I get nausea. Well, it's not necessarily a drug allergy, it's just a side effect. So there's a difference between side effects and drug allergies. So it's important to know the drugs and know the difference between side effects and allergies, because then it could possibly prohibit the patient from using a drug. Like, for example, if we have penicillin allergy, then the rest of their life it's on that as an allergy, and so we get nervous. Are you going to go into anaphylaxis when you take this drug? And a lot of the elderly people like, I don't know, I've been just told that I was allergic to it as a kid. So it's important to really now identify what happened with the specific drug. Was it a rash? Was it anaphylaxis? Was it nausea? Was it diarrhea or just stomach pains? And those are that's just a side effect, whereas anaphylaxis obviously is not, and hives are more of an allergy. Okay, so drug allergies, the body forms an antibody to the drug. It just doesn't like it. Your body's saying, nope, I don't want you. You can have an anaphylactic response, cytotoxic response. Again, these have to do with antibodies and your body's response, serum sickness, and then the last one is delayed reactions. So what I'm going to focus on here, this in a nutshell, like a cytotoxic reaction and serum sickness reaction actually can happen from 1 day to a week after the drug exposure. A delayed allergic reaction will also happen days after. They both have somewhat different side effects to them, but I want to focus on the anaphylactic reaction. That's life-threatening if it's not caught right away, and as you know, you can have anaphylaxis from like a bee sting, so other things too, but drugs can also cause it. Some drugs more than others. You'll find that in the safety and precautions area when you look up a medication. So anaphylaxis, the patient has trouble breathing. Your bronchioles start swelling, your throat swells. Sometimes people all of a sudden have a tingling in their mouth, they're like something's going on, and then you get the throat swelling, your bronchioles become swollen up, so you need to get some adrenaline or epinephrine injected so you can constrict the blood vessels, help blood flow, and relax the bronchioles. It's your sympathetic versus parasympathetic nervous system. So understand anaphylactic reactions with certain medications. You can have tissue and organ damage to taking medications. So while medications are great and they are so helpful, we just have to always be aware of the adverse reactions to it, and then it can cause tissue and organ damage. These are just some of them here. So many of these, when we think of chemotherapy drugs and the anti-neoplastic agents, we can have all of the above reactions. Think about radiation. If we take, let's say, gabapentin, which is for peripheral neuropathy, it's used for migraines and sleep and nerve pain in general, that can cause central nervous system effects. These can be side effects, or they can actually cause tissue and organ damage. All right, so let's talk about the different types of adverse reactions you can have. Very common, rashes, hives. So if someone's getting IV morphine, if they get a rash, we're like, oh, it could be from the morphine. There's some drugs that cause rashes more than others. Like antihistamines are less likely to cause it because we're taking an antihistamine. So remember, histamine means inflammation. If you have a reaction, usually there's a histamine release, and that's what causes the redness in the hives. But if you're taking an antihistamine, then that's supposed to block those histamine receptors. So rash and hives. Usually you just take the medication away and it'll go away. Stomatitis, where you get inflammation of the mouth, mucous membranes, common in the anti-neoplastic agents. And it's basically making sure you're doing frequent mouth care. That's in the textbook, so make sure you review that. Superinfections, destruction of the body's normal flora. This is common with antibiotics, again, anti-neoplastic agents, because it's killing not only the bad bacteria or inhibiting that, it's also inhibiting the good bacteria or killing the good bacteria, depending on the action of the drug. So this is where we have to give antifungal. So if they have a vaginal infection, maybe I'll give a local prescription, such as you can get Vagisil over the counter, or there's Monostat or clotrimazole I can write as a prescription at a higher strength, or I can just prescribe them diflucan, which is an antifungal medication that's an oral pill. And usually you just take the pill once. You can repeat it in 5 days. But again, if you look up that drug diflucan, there's different ways, or fluconazole is the other name for diflucan. Sorry, diflucan's brand name, fluconazole's generic. I'm trying to remember to let you know that. You'll look it up and you'll see different doses for different types of infections. Blood dyscrasia, bone marrow suppression, chemo agents. If you're having chemo agents from cancer, you're going to get bone marrow suppression because, again, it's killing off other cells in addition to the bad cells. These people you have to be really careful with because they can pick up an infection very easily. If you have bone marrow suppression, you have to watch their blood count. So I put a CBC in here, and you don't have to know this for an exam, but it's just for your own knowledge. When we say bone marrow suppression, when we say blood dyscrasia, we are saying things are off here in your CBC. So some cells that you need are being destroyed. So, for example, your WBC in a chemo patient, when they have bone marrow suppression, this will be less than this value. But please note that every lab is different. So while this lab's 4.8 to 10.8, another lab may be 5 to 10, or 4 point something to 11 as being normal. It's like that with a lot of labs. We just kind of go do our best, and we just know what's normal at the facility that you're in. So this will be low. Your hemoglobin and hematocrit will be low. They'll be anemic. So this has to do with infection, your WBCs. All of this down here is a breakdown of this white blood cell. So these will all be off if you have bone marrow suppression. Hemoglobin, hematocrit, MCV, MCH, MCHC, RDW. That all has to do with your red blood cells and the types of anemia. But again, if it's killing off cells, you will have a low hemoglobin, hematocrit, you'll have a low RDW most likely, and these will be off. You're going to learn a lot more of that in the next couple semesters. Your platelet counts have to do with clotting. Those will be low also. Sometimes we have them dangerously low. It has to do with blood clotting, and it can thin your blood too much. All right, liver injury. We see this sometimes with statin medications, although not as much. We just have to monitor the dosing, but you can. No different than alcohol causing liver injury. And what do? You discontinue the medicine. Renal injury. Sometimes we need to change the dosage, but I see renal injury a lot with people taking NSAIDs. That's the first thing I ask. And actually, when you have an abnormal liver enzyme, liver injury, which is AST and ALT, is one of the most common if you get a liver panel blood test. You don't have to know this for the test. I'm just telling you for knowledge. Renal injury, if you see your BUN and creatinine, which is, again, part of the complete metabolic panel, then first thing you do is look at the drugs. What kind of drugs are they taking? Many times you have to eliminate the drug or adjust the medication. Poisoning is an overdose of medication, so you can die from it. So Tylenol can cause liver failure and you can die. Some are more lethal than others. Like tricyclic antidepressants are notorious for being fatal. It's very dangerous. That's why a lot of people don't prescribe them to like teenagers, and we try to stay away from that class of drugs. Whereas SSRIs, yes, you can overdose. It could be fatal, but it's less likely than taking the tricyclic class of antidepressants. Ibuprofen is the same thing. Actually, my granddaughter got a hold of ibuprofen, and they didn't know how much she took, but went to the ER, and the ER was like, well, I'm glad it wasn't Tylenol. We'd be much more worried about that than ibuprofen, just because of the liver metabolism with Tylenol. All right, so let's talk about glucose and electrolyte metabolism. Hypoglycemia. In a nutshell, with hypoglycemia, you feel like you're dying. You feel like you're going to go at any moment and pass out. You get extreme anxiety and panic feeling, headache, fatigue. You just feel like you're dying. You have to give them glucose. Even if you're not sure, we check a blood sugar. Even if we're not sure and we don't have a blood sugar monitor with us, we're like, here, have some juice. Because that's an easy treatable thing. And if it's not, it's no big deal. Yeah, it'll bring your blood sugar up, but it's more dangerous in the moment to have a low blood sugar than it is too high of a blood sugar. Too high of a blood sugar has problems over time. So, hyperglycemia. If you have hyperglycemia, you are thirsty, you're hungry, and you're peeing all the time. So, I'm diabetic. I'm type 2 diabetic. I can tell when my blood sugars go up because I'm hungry. And I'm hungry. I'm hungry a lot. These people need insulin. I don't take insulin. I am diet controlled completely. But some people and a lot of people need insulin to control that. Hypokalemia. What I want you to remember with hypokalemia is that, and I know you're learning this in patho, one of its main mechanisms is muscle conduction and contraction. And the heart is a muscle. And if these are off, cardiac conduction can be off kilter. So you can go into a dysrhythmia, VTAC, and you can die. VTAC to VFib, and then that's not good. So with these people, with these electrolytes, and if you ever see anything on an exam, most likely there's going to be a choice on there to either put a EKG monitor monitor it, cardiac conduction, arrhythmias. You're going to see something cardiac, and that's usually always the answer when you see potassium as an issue. Low potassium or high potassium. Very dangerous to the heart. Eye damage, hearing damage. We see auditory damage from older antibiotics. Such as gentamicin. Gentamicin is notorious for that. It's not given as much anymore, but it's still found on NCLEX exams, so you're going to be learning about gentamicin a lot, or hear about it. But again, you discontinue the medication. People that have ringing in the ears, it could be you're getting too much aspirin. Central nervous system effects, confusion, delirium, insomnia. These are usually from the drugs that cause that, like your benzodiazepines like Xanax and Valium. Gabapentin I talked about earlier. That is for neuropathic pain. Some of the just drugs to narcotics can cause that also. And so with these, you want to prevent injury. So that's why you get a prescription sometimes that'll say, do not drive or operate heavy machinery. And that means, like, basically, just be careful. There's some anticholinergic medications. Anticholinergics, think of it as drying you up. Atropine's one of them, which like it says atropine-like, but all the overactive bladder medications, antimuscarinics is another name, they're anticholinergics, such as Vesicare, Enablex. I don't know if you remember the commercial, gotta go right now. I think that was Enablex. I don't know. Myrbetric's another one. So people that have overactive bladder, where you run in the house and you feel like, I gotta go to the bathroom, every time you come home, it's probably overactive bladder. Your bladder muscle is spasming. Your brain is telling your bladder, I gotta go, just because I drove up my driveway. It's a very strange phenomena, but it is. But that can cause a lot of dryness, constipation. Again, we don't take this patient off the medication necessarily unless it's bothering their daily life, but we can adjust the dose if it's working for them and doing what it's supposed to be doing. Parkinson-like syndrome, a lot of the psychiatric meds will do that, meaning more antipsychotics, can cause the muscle tremors and tardive dyskinesia, where you're like sticking your tongue out all the time, and then neurologic symptoms. This has to do with what we've talked about already, harm to the fetus. And we don't want to give medications with known drugs that are known to cause fetal malformation. That's a big no-no. The other ones, remember we talked about category C, B, you have to weigh the risk versus the benefits. All right, and that is it for this slide set.